Good evening. I'm Mai Miksic. I'm the Early Childhood Policy Director at Public Citizens for Children and Youth, or PCCY. Thank you everyone for joining us tonight. We're very excited about the lineup of presentations and speakers that we're going to have tonight. This town hall is focused on parents and parents who have questions about going back to childcare, COVID safety at childcare centers, or general COVID safety in questions. Just a couple of housekeeping items before we get started. There is a Q&A function on Zoom, so if you would like to submit questions, please use that to submit your questions. We are going to wait until the end to do questions, but go ahead and submit them anytime during the presentation if you have them. Please leave the questions in the Q&A and leave the chat for comments so that we know kind of where to go to look for the questions. And just want to let everybody know that this presentation is also being recorded and is live on Facebook. And with that, I'm going to pass it to Sean Perkins, who is the Chief of Early Childhood Education at the Office of Children and Families. Sean?
Thank you, Mai. Again, my name is Sean Perkins. I'm the Chief of Early Childhood Education with the City of Philadelphia. I want to say thank you to PCCY and CHOP and PDPH, as well as ELRC number 18 in the School District of Philadelphia, who are all contributing today. If I understand well enough that you are all parents and guardians of children, like myself, I have a 4-year-old and I have a 1-year-old. I understand that right now it's very confusing and a lot of information is coming at you for what childcare looks like. Not to mention it's 5 o'clock on a Thursday evening after there was a lot of snow that came through Philadelphia. So if you're paying attention, please try and listen along. If not, it's being recorded so you can share it and you can highlight the parts that you want to share with your friends and neighbors. But the goal here is to have experts share with you all why it's important to return to childcare and why there are safety measures in place to make it safe for you to return. With that, I'll turn it over to more of the experts here. Gail Carter-Hamilton, who's been an incredible colleague and an advocate for all of childcare and for parents and families across the city. Gail Carter-Hamilton with the Philadelphia Department of Public Health. Thank you, Gail.
Good afternoon. Thank you, Sean, and thank you, PCCY, for having us so that we can demystify COVID and provide the best guidance that we can. My name is Gail Carter-Hamilton. I am a nurse. I've been a nurse for 23 years. I am the Pediatric Partnerships Manager within the COVID Containment Division at the Philadelphia Department of Health. And my job is to help schools and child care centers mitigate the spread of COVID within their buildings. And I would like to be able to toss the ball over to my other colleagues here at PDPH to introduce themselves. Tanya?
Yeah, because I committed to this trip.
Thank you, Gail. Good evening, everyone. So my name is Tanya Dingra, and I am the Pediatric Resources Coordinator for the Philadelphia Department of Public Health. It is absolute pleasure to be here tonight and be part of such an esteemed panel. And I think I will jump right into the presentation tonight, as I want there to be plenty of time left over for questions. So I'm gonna just wait for my cue. Thank you. So thank you for being here tonight. We are presenting tonight to make all parents today feel absolutely more confident in their efforts, as well as ours. So going back to childcare, this is a parent town hall on COVID safety. And it's being, we have a lot of different speakers tonight, and I hope that everybody has a chance to listen. Next slide. Thank you. So I wanted to kind of start with these glossary of terms. I know that by now these terms have been hammered in, and you've probably heard this multiple different times, and they've become household terms by now. Before the pandemic, they were not so much. But isolation means staying in a separate room from others and using a separate bathroom, avoiding contact with other household members and pets, and not sharing personal items, including utensils, cups, and towels, etc. We will later kind of talk more about how this pertains to individuals who are confirmed positive for COVID-19. Quarantine means to stay home for a period of time per the CDC guidance, and this is usually after last contact with somebody who might have tested positive, or you are watching for symptoms like fever, cough, shortness of breath, new loss of taste or smell, and also staying away from others as much as possible. This could be as a household or also as an individual. Next slide. So close contact. I know that this is a little bit of this is a term that is a little bit, I want to say, more public health based. And usually these are individuals who fall into tier 1, which is the highest risk for transmission, or tier 2. And regardless of their face mask use, we ask that they almost always have to quarantine for a certain amount of time. And this, in a school education-based setting, is anyone who was within 6 feet for 15 minutes or more over a 24-hour period. Anyone in the same cohort. This depends, again, on various different ways that one is cohorting their site, facility, school, education-based setting. Anyone in a shared office, so adults. Anyone carpooling to and from the city. This also includes buses as transportation. Anyone eating lunch together. That could be, adults eating in a shared space, individuals who have had contact within, 6 feet or a total of 15 minutes or more. They are all deemed as close contacts of an individual. I wanted to also go over the other definitions that you might hear tangentially. A confirmed case is somebody who has a confirmed test for COVID-19, whether it be a PCR test or an antigen test. A probable case is somebody who meets the clinical criteria for this virus. So whoever may feel like they have flu-like symptoms, respiratory symptoms, or what we call here an epi-linkage, epidemiological linkage, with no confirmatory laboratory testing, which in layman terms just mean if you're a close contact and you may be symptomatic. Next slide. So these were a couple of questions that I think we wanted to answer that we got from parents before this presentation. And the first is, are the signs and symptoms the same as adults? And that is yes, they are. Could we have the next little, I think I added a little, perfect, thank you. They just tend to have milder symptoms, or in some cases also symptoms regarding their, like an upset stomach, usually. How many children are being hospitalized? There are 20 times less risk of hospitalization than adults. How sick can children get, and have any died? ICU care for children in a pediatric facility are rare. Approximately 100 children have died in the US due to the virus. So this is an overview of the transmission that I would like to now, I think, hand this over to Dr. Susan Kaufman.
Hi, everyone. My name is Susan Kaufman, and I'm a pediatric infectious disease physician who works both at CHOP as well as at the Philadelphia Department of Public Health. And as a pediatrician, I've been really interested and concerned about how we take care and take care of the children in our city, as well as educate their families around COVID. So I was pleased when I was asked to join this session to talk a little bit about transmission and hopefully clarify some things that have remained a bit confusing. Great. So one of the things I think is really important to underline is, after a year, we actually have a lot of good data about how does coronavirus pass person to person. And the overwhelming most common ways in which this virus are spread are through droplets. And these are droplets that come out of our mouth, obviously when we cough or sneeze, but also when we're laughing, singing, and even just chatting. One of the things that distinguishes these droplets is that although they're basically invisible, they do have some weight to them, and they have enough weight that over the course of about 6 feet, virtually all of them are pulled down to the ground. And you can see that illustrated in the little graphic right next to the on the slide. So this is in contrast to viruses that are spread by the air primarily. For those viruses, those are viruses that go into something called an aerosol, and they can just float around and travel here, there, and everywhere. The good news is coronavirus is not one of these viruses, and we know that for a couple of reasons. One is that when we have somebody get sick in a large family and be at home with their large family because they can't quarantine, let's say, not everybody in that house is going to get sick from coronavirus. What we know is that somewhere on the order of 1 out of 5 people typically get sick when there's a household case of coronavirus. So if this was an aerosol spread virus, this is the situation where you would have 100%, every single person in every single house that had one case of coronavirus would end up with everybody having coronavirus within 2 weeks. And so that's probably the most important epidemiologic reason why we know that this isn't a major route of transmission. The good thing about droplet transmission is we know what to do. And the things to do are all based on the fact that the droplets can be caught by masks. They can be blocked by partitions or a mask. And we can encourage them to settle between people by having a greater than 6 foot distance between people. And so that really kind of gives rise to those very common and very basic principles we've all been hearing and living by for so long now, of wearing a mask, staying 6 feet or more away from people, making sure that if you have to remove your mask, you are definitely at least greater than 6 feet away, and that you aren't around people who are sick, nor should you go into any place if you have any symptoms or been recently exposed to coronavirus. Next. So one of the questions that's come up over and over again is, what's the role of viral contamination of the area in which we live to causing transmission? We do know that this is a virus that can live for a little while on a surface after somebody, let's say, has sneezed and failed to cover their mouth before they sneezed. The virus can, in fact, be left in a live form for a little while on, let's say, a table. But the thing to remember is that in order to cause you any problem, you would have to touch that table while that virus was still there and still alive. And then you would have to get a lot of it on your hands. And then you would have to put your hands directly into your mouth or into your nose or into your eyes in order to transfer it. Those 3 things would have to happen in order to make it even possible for the virus to be transmitted from a contaminated surface or item to you to get an illness. So what do we do to prevent it? It's really the tried and true stuff. Hand cleaning is probably the most important thing. And hand cleaning and remembering not to touch your nose, mouth, or even eyes with your hands is really an effective way to keep this type of transmission from happening. There also are ways, particularly in early childhood education, to enhance environmental cleaning. We talk a lot about perhaps increasing the frequency of what we call high touch areas. That may be the countertop where you're frequently setting things out, the light switches, and of course the bathroom. So you may want to up the frequency with which you are cleaning those areas, but it does not mean that there needs to be a once an hour wipe down of the entire room. Next slide. Next, please. I thought I'd spend just a few minutes talking about this new card test called the Binax Now, which is becoming more and more commonly used at testing sites and has some possible applications to testing in school settings.
I do have a radio runner.
Oops.
Oh.
I think we had an accidental speaking up. So about the card test is this is a test that can be done very quickly and can be a good way to diagnose people who have new onset symptoms. So symptoms that have happened within less than 7 days. It's great to use in settings where it makes a difference to know immediately whether or not somebody has coronavirus. And that might be in a daycare-like setting where knowing whether or not the child with fever and stuffy nose, who seemed fine when they came to school, but now all of a sudden isn't, has coronavirus, because that would make a big difference, as you heard from Tanya, about how we decide to handle the cohort, which may have been exposed. We do know that these tests are not quite as sensitive as PCR tests, but they actually do work pretty well with about 93% sensitivity if we use them to detect people who are actively infected, and meaning that they could spread the virus and are symptomatic. Next slide. And I think I'm handing this over to
Gail.
Gail. Oh, yes, Gail. Very good.
Thank you, everyone. We just wanted to give an overview of what the coronavirus looked like here in Philadelphia since last year. If you look to the left here, you'll see when the initial surge occurred just prior to our shutdown in March of last year, and it will extend all the way through the end of last year. One thing I wanted to point out is where you see that sharp increase right around 11/1. What we do know is that sharp increase was really spurred on by activities surrounding Halloween. So this slide is basically just to inform people that your activities outside of the school setting is just as important as the mitigation efforts that the schools are doing. Next slide, please. And this is another slide that gives case counts by type of school. And the orange there represents child care centers. And you can see that the peaks there will correlate with the other slide that just passed. We can look also right around Thanksgiving or so, where we start seeing a downward trend of cases is when we decided to reenact some of the restrictions that were in place earlier in the year. Next slide, please. This is just another representation of the previous slide, just more focused. And what we also wanted to speak on here is what happens, why we believe it's safe for schools to open and childcare centers to remain open. One of the things that my team looks at is to see if there is actually in-school spread. So what does that mean? If John Smith is a second grader and he sits in a classroom or he sits at a round table in a childcare center, is there anyone else within his classroom that is testing positive at the same time? And what we're seeing here in the Philadelphia Department of Health is that is not the case. We are not seeing a lot of in-school or in childcare center spread. And when we do our contact investigation, what we're seeing is that there's a lot of link to behaviors outside of the school. This is parties, attending funerals, attending weddings, and other so it causes some exhaustion, but we wanted to stress the importance of watching your distance. And next screen, please. Next. So again, key principles for education-based settings, masks. Like Dr. Kaufman, my colleague, had mentioned earlier, we do a layered approach and when we're looking at COVID. So one of the base and the foundation of our teachings will always be mask use. Mask use is fundamental in preventing the spread. Additionally, we speak of social distancing. We have met with school districts and childcare centers and childcare center advocates on the importance of cohorts and keeping them at 25 or less, ensuring desks and space are 6 feet apart, and weather permitting, meals outside, or if that's not possible, assigned seats in the cafeteria. Seating charts would be permissible. Next, hand hygiene. Just like Dr. Kaufman had mentioned, hand washing is another layer to this layer cake, if you will, to make sure that we can mitigate the spread of COVID. That means 60% alcohol at your centers if possible, and simple soap and water. It's not very hard to kill COVID. So what we do know is these efforts with hand washing and hand hygiene, they actually work. And additionally, the screening of students and staff prior to entry into the building. Next slide, please. I'm sorry, next point would be also we want to make sure that you plan what happens when you get sick. All of the schools and child care centers have been asked to forward a health plan to the Pennsylvania Department of State Education Department so that everyone knows that there is a plan in place at child care centers and schools. This is a requirement, and all of the schools and child care centers have followed suit, and some of which have asked us to review them to see if there is anything that they may have been missing or if there's any gaps. And I'm happy to announce that almost all of the schools that we have verified their health and safety plans, they are all doing a fantastic job. So with this plan, in the plan, we have also asked that they make sure that they know that they give the parents notice to let them know, have a plan when someone's sick. If you are sick, stay home. If your child is sick, we would also encourage you to keep the child home. If you're seeking testing because you're experiencing COVID-like symptoms, we would ask that you do seek the testing, but stay home until you have those results. That is very important for us to know if we need to give your school or you guidance to be able to further mitigate the spread outside of your home setting. Next slide, please. So one thing I wanted everyone to be aware of is that it's not about if COVID comes to your child care center. COVID will be there. It's a matter of when. Our job at PDPH, in comparison with CHOP and other colleagues here on this line, is to give you the preparations that you need and help you to feel empowered and informed of when this happens. We know there's a lot of fear surrounding COVID, but we're partnering with all of these organizations, and we will partner with you, the parents, to make sure you feel safe to go back to school. Next slide, please. So ultimately, our goal is to keep schools and childcare centers open, but not just open, keep them open safely. So currently we have about 125 schools and roughly 1,700 childcare centers that are open and functioning and operational at this time, or hybrid model. And we have had very few schools report what we call in-school clusters or in-school outbreaks. This is great news and fantastic. And with this, we believe it is safe for schools to open. Next slide. So I wanted to show this. This is actually a meme that was pulled from social media, but I think it's a great representation of what it actually looks like to be outside of your bubble. We say the word cohort quite a bit, and cohort is not exclusive to just schools. So I want you to think beyond a school classroom. A cohort could also be a bus. So if you have a child that takes a school bus to school or to childcare, that is in essence another cohort. There's also cohorts within soccer. If you go to another friend's home, that someone that does not live within your household, that is another bubble. So what we wanted to show you with this slide is to make sure that you're aware that you hold the key to also make sure that you maintain the integrity of your schools. We would like the schools to stay open so that we can give children the least restrictive environment for their learning. And this begins with you. Your behavior outside of the school is just as important as what the school does. So please take note of this meme. Next slide, please. So if you believe that there was a COVID-19 case at your facility, or you have questions, you would like to speak with someone in authority at Philadelphia Department of Health related to schools, you can call this number located on the screen here. It's 215-685-5488, or you could email covidschools@phila.gov for further instructions or guidance that you would need as a parent as well. I also wanted to make sure that you are aware of community testing sites, the CHOP COVID testing tool, and the St. Christopher's COVID-19 testing. If you should have any information or would you like further information about these, we will get them to Sean Perkins as well as the ELRC to send out in our newsletters. Next slide, please. So next we'll be speaking on vaccines, and I will pass this over to my colleague, Nicole.
Thank you, Gail. My name is Nicole Spector. I'm a nurse practitioner. I work at the Philadelphia Department of Public Health Immunizations Program. So myself and Dr. Julianne Burns are going to be speaking a little bit about the COVID-19 vaccine and its rollout specifically in Philadelphia. So I'm going to be speaking more specifically to the two vaccines that we have available right now. So the two that you may have heard in the news or seen are the Pfizer vaccine and the Moderna vaccine. So those are two different manufacturers of a very similar vaccine. And they are the two that have so far been approved under an EUA. An EUA is an emergency use authorization that's provided by the FDA. And that's what allows us to administer both the Pfizer and the Moderna vaccine, because they conducted some very big clinical trials. And then they determined that after these clinical trials, both vaccines were safe and they were effective for preventing serious COVID-19. And they determined that the benefits of these vaccines outweighed any potential risk. So just to go over each vaccine in a little bit more detail, the Pfizer vaccine, it's what's known as an mRNA vaccine. It requires ultra cold storage. It's a 2-dose vaccine given 21 days apart, and it is approved for people ages 16 and up. And the Moderna vaccine is also an mRNA vaccine, 2 doses, but this one is given 4 weeks apart or 28 days, and it's approved for people ages 18 and up. And they both have been found to be about 95% in preventing that severe COVID-19 in clinical trials. We don't know how long protection from these vaccines might last, and that's something that we're going to find out over time as more and more people are vaccinated. And one other point just about what is an mRNA vaccine. You might have heard of vaccines in the past. They give kind of a weaker version of the virus, and that teaches our body to have an immune response. But these mRNA vaccines are a little bit different. So without having any weakened virus or a live virus, they're able to teach our bodies to create this immune response without exposing us to the actual virus. Next slide, please. Thank you. So why get vaccinated? The vaccine decreases our chances of getting sick from COVID-19 virus. It reduces spread of the virus, and it helps to keep our family, friends, neighbors safe. So as I mentioned before, none of the current COVID-19 vaccines actually contain the live COVID-19 virus. So you cannot get COVID-19 infection from the vaccine, and you will not test positive on a COVID-19 viral test. If you've had COVID-19 before, we don't know how long the natural protection is from having had the virus. So it's still important to get vaccinated so that you have that protection. Next slide, thank you. And do I still need to use precautions after being vaccinated? The answer is yes. It's very important for people to continue to use their masks, social distance, wash their hands, everything my colleagues before me have mentioned to you all. The vaccine, again, is another layer of protection that we're hoping, a lot of people will be able to access in time. And it does take time for the vaccine to be fully effective, about 1 to 2 weeks after the second dose. So that's why it's very important to make sure you get both doses and to continue to wear your mask, wash hands, and socially distance. Probably even, we don't know how long after you get the vaccine, but we don't know how many other people are vaccinated in the community, and we don't know yet if people can be asymptomatic spreaders if they are exposed to COVID-19 after they get their vaccine. And now I'm going to turn it over to Dr. Julianne Burns.
Hi, everyone. My name is Dr. Julianne Burns. I'm a pediatrician at the Philadelphia Department of Public Health. And excuse my mask, I'm just finished working at one of our clinics today. So I'm just there, but please let me know if you have trouble hearing me. So I wanted to speak a little bit about the COVID vaccination program in Philadelphia. As you know, we are getting, after the vaccine was approved, we are slowly getting more and more supply from the companies who make the vaccine. At first, there's only a little bit of vaccine available, but every week we are getting more and more and more. So there are different phases that we use to help make sure that the people who need the vaccine the most and are most at risk of getting sick from COVID-19 get the vaccine first, as well as critical workers who are exposed to COVID-19. So I just wanted to demonstrate for you this diagram, which shows some of the phases. Phase 1 is where there's limited doses available of the vaccine. And so Philadelphia has phases 1A, 1B, and 1C as we get more and more of the vaccine. Phase 2 is when we know that there will be a larger number of doses available, and we feel like there will be enough sufficient supply in the population for everyone who wants to get a COVID vaccine. And phase 3 is where this COVID vaccination will become routine for people who have not yet gotten it. Next slide. So the phase that we're currently in Philadelphia is we have moved from phase 1A to phase 1B. And in phase 1B, this includes childcare and education providers, which is highlighted below. So there will soon be opportunities for child-facing staff to receive vaccine, and there might be more than one opportunity, but one opportunity that is currently being developed is a partnership with the Children's Hospital of Philadelphia. Next slide. So these are some common questions that we wanted to address. The first question is, are schools safe to open if not all staff have been vaccinated? And the answer is yes. And as Gail mentioned in her presentation, schools should follow the principles described for education-based settings. Another common question is how long it will take to have all of Philadelphia vaccinated. The answer is this will depend on how many vaccines are allocated to the city by the federal government. We hope that this will continue to increase as more vaccines are manufactured. You can track how many people in the city have been vaccinated on the Department of Public Health website. So if you go to the website, you go to COVID-19, and then you specifically go down and choose vaccines, like COVID-19 vaccines, and then data, you can find all the statistics that are updated regularly of how many people have gotten the vaccine in Philadelphia. So again, this might take some time at the current supply of vaccine that we are receiving weekly, but we hope that as the weeks and months go on, we will receive more and more. And so more people will have the opportunity to be vaccinated as quickly as possible. And the third common question is, how do we know when it will be time for my child's school to be vaccinated? So the answer is that clinics are tentatively scheduled to start at the end of February. But the specific clinic dates are to be determined, and your child's school will be notified soon about opportunities for their child-facing staff to be vaccinated. Next slide. So on this last slide, we wanted to just show you some of the ways that you could sign up to receive a vaccine in Philadelphia. So the first is to go to the Philadelphia Department of Public Health website, and there is an interest form that you can fill out. Just to emphasize, this form is not a place to schedule a vaccination appointment, but it is to express interest in the vaccine. And then when it is based on the information you fill out, when it is your turn to get vaccine, you will be notified by the health department of opportunities available for vaccination. So you'll see on the website, there's a nice yellow bolded banner that says reserve your place in line for the COVID vaccine, sign up today. So you just click that and fill out the form. And then they will have your email address to be contacted, where you can be contacted when the opportunity is available. A second option is to call the COVID-19 hotline that's run by the health department. And if you don't have access to email or the internet, or want to pass this on to other people who don't, you can give them this number and they can call and they can help the person fill this out. And then they can provide their phone number, and we will also call them about opportunities for vaccination when it is their turn. And if you have questions about eligibility based on health conditions for vaccination, please contact your health care provider to discuss, and they can help help you determine what category you might be in based on those health conditions, and also based on occupation. There's more information about the different phases in Philadelphia and vaccination available on the website and who fits into what category. So a lot of information available on the website. I think I also listed just the website again at the bottom. This also has a list of, in addition to information about the vaccine generally and our vaccination program, we also have frequently asked questions. So many more questions than we answered today in the presentation, all about vaccination. So this is a good first place to go to see if your question has been answered. A lot to look through, and then and there are other resources available as well. So next slide. I think that was the last slide, I think, of the presentation.
Thank you, Julianne. I'll take over. So now what we want to do is move to the question and answer portion of our evening, and I'd like to pass this on to Michelle Lindercoats from the School District of Philadelphia, who is the Executive Director for Early Childhood.
All right,
Nicole?
thank you, Mai. Yep, thank you, Mai. Good to see everyone, and there have been some questions around the school district and in the different topics surrounding ventilation, asbestos, and things like that. So I just want you to know that we do not have the answers to those questions at this time. And specifically, we will be responding to questions related to childcare and COVID mitigation. So I just want folks to know that ahead of time.
I'm sorry, Nicole. I forgot that we were going to jump to Damaris before Q&A. Can we do that first so that
Sure.
She's going to answer some of those questions, so we
Great.
might as well get that. All right, I apologize, everybody. I'd like to introduce Damaris, who is going to talk about the COVID precautions that she's been enforcing at her childcare center. We're very lucky to have her with us today. Damaris?
Thank you, Mai. My name is Damaris Alvarado. I'm the owner of Children's Playhouse, Whitman and Newbold in South Philadelphia. And I want to thank PCCY for inviting me to share the COVID-19 safety precautions that we have put in place in our centers. Some of these precautions are purchasing approved cleaning chemicals, purchasing outdoor barriers to keep our students safe during pickup and drop-off times, purchasing additional tables and screen guards for most classrooms to promote social distancing for our older children, create staggered drop-off and pickup schedules to support 6 feet social distancing guidelines. All of our students over the age of 2 wear masks daily. All of our staff wear masks daily. Longer outdoor play schedules, installation of air purifying units in every classroom to increase air quality, hired additional staff to support transporting children into their classrooms and to take them to the door during drop-off, implementation of screening procedures during drop-off, which include temperature checks, administering of hand sanitizer, spraying children and staff shoe soles with 99.5% alcohol, and asking a series of screening questions prior to accepting children and staff entering the building. Installation of hand sanitizing pumps in and out of each classroom that is out of reach of children. COVID-19 mandatory tests for all of our staff every 2 weeks, just to be as an extra precaution. mandating staff that have children that are under 2 years old or that cannot properly wear a face mask to wear a face shield, in addition to the face mask for added protection. Limiting cohorts to make sure that children are staying within the same groups daily. Disinfecting schedules. So we implemented this disinfecting and cleaning schedules on a weekly basis so that we're doing that intentionally in addition to the daily disinfecting and cleaning that we do every day. Most importantly, apart from all these thousands of procedures that we have implemented, it's the partnerships with the families that we have, having meetings on a monthly basis to review and share procedures, asking families if they feel safe, and if not, what can we do to improve our overall health and safety guidelines and COVID-19 procedures, and being as transparent as possible and share positive tests if we have any, or exposures with families in a timely fashion. So those are the things that we have taken in place at our Children's Playhouse centers. Thank you, Mai.
Thank you, Damaris. And now we will go to the Q&A section. So Michelle, you can take over.
Sure, great. And thank you, Ms. Damaris, for that, for sharing all of the procedures and processes that are newly implemented as a result of this. First question, how are residential window fans suitable for classrooms and not for restaurants? And I guess here we just want to talk about, or if you could respond to residential fans and their use and if they are effective in our spaces. Because
thank you, Michelle. So yes, I understand the question, but I can only answer in relation to schools.
That's right.
So the way I explain this is generally how we look at a layer cake. We do a layered approach for COVID mitigation. The more layers, the better, right? If there are layers that we can't get to, so for instance, there's no plexiglass shield in the classroom, you would want to beef up the other layers. This added layer of adding the ventilation with a fan allows air to be circulating. And if you remember what Dr. Kaufman had mentioned, that a lot of these droplets kind of move out into the air and they kind of fall to the floor. They're pretty heavy. So the fan helps to mitigate and make sure that those droplets don't swirl around in the air. They kind of pushes them out of the way and drops them to the floor where they are inactivated and unable to be breathed in by others. Outside of fans, other ventilation measures that can be used would be something simple like opening up a door and an opposing window to allow the air to flow through the room, or moving a cohort to a much larger area to be able to dilute the air surrounding individuals where COVID could spread. I don't know if Dr. Kaufman would have anything to add to that.
No, I think that's absolutely correct. You know, I think what we know is that, you know, the ways to dilute and diffuse the ways to dilute and diffuse any coronavirus particles that happen to be present is to bring in fresh air, get rid of old air, and frankly, just to stir it, to move things around. It's a lot like putting drops of food coloring into a gallon of milk. You know, one drop of red food coloring is not going to turn an entire gallon red. And there's a big dilution factor that happens when, you know, if any particles get introduced.
Thank you, ladies. Next question. This is regarding isolation in the home. Please address how larger families who do not have the luxury of a separate room may help to minimize risks.
That's a good question. So I guess we have to look at it in the respect of if there is a positive case that's within the home. That's the best way to look at this. If there is a case, a positive case in the home, the recommendation from PDPH would be that there would be mask use. We would still like to see isolation away from the other individuals. That would mean a separate bedroom and utilizing a separate bathroom, but we do recognize that that may not be possible. So what we would recommend is that there would be mask use within the home to assist with the prevention of spread within the home. However, what we do know is that there are household exposures that do result in positive tests and positive cases. the best way to do that is to wear a mask while you're in the home. If you're having trouble with finding masks or you need assistance with finding appropriate PPE for individuals in your home, you can please reach out to us via that email, covid.schools@phila.gov, and we can assist you with that.
Thank you. Next question. Are the facts about droplets versus airborne transmission also true of the new and more aggressive variants?
I'm going to throw that one to Dr. Kaufman.
Hi, everybody. I'd be glad to talk about that. The quick answer is yes, absolutely. The good news is that these variants vary by just a few nucleic acids, such incredibly small particles of the virus that they basically can't be detected until very complex science is done in order to detect them. They make no significant difference to the structure, size, or weight of the virus, and no difference to the way it gets expelled from the body in droplets. So we're quite confident that we need to keep on wearing our masks and that our masks will work. The only thing that I would say about it is having these variants potentially out there just makes me feel like I really want to wear my mask, not just kind of want to wear my mask. So I'd encourage everybody just to kind of double down and make sure they've got a good quality mask and that they're keeping it on when they're in public or with kids.
Thank you, Doc. Next question. How do we know the rate of infection in the absence of widespread testing of children in schools?
I'd be glad to share some information I have from Children's Hospital. At Children's Hospital and at St. Christopher's too, we actually do a lot of testing of children of all ages who are asymptomatic. And we do that when a child needs to have a surgical procedure or needs to be hospitalized because the risks of transmission change sometimes in the delivery of complex medical care. So we test a lot of kids, now up to thousands of kids who have no symptoms at all. And I can tell you right now that amongst the children that we're testing and who have no symptoms, they have less than a 1% positivity rate. And I really think that, you know, this scenario of there being a lot of kids who have unrecognized infection is just not something that we're going to be seeing going forward, particularly if the viral burden in our city continues to drop as quickly as it has been.
Thank you. Next question. When will we have access to the Binax Now testing? Can that testing be done by non-medical personnel?
Gail, would you like me to make some comments about that?
Yes, please.
Sure. I don't know when the Binax Now testing will be broadly available in early childhood education settings. I think that there are really interesting opportunities to use it and would love to see some of the logistic challenges overcome. The couple of things that I can tell you about is that you don't have to be a clinical or medical person of any kind in order to do the Binax Now test. However, there does have to be somebody with a clinical background, a nurse, a nurse assistant, a physician on site if the Binax Now card is being used for testing. And that's been a bit of a challenge as I've had conversations with different individuals who provide early childhood education.
Thank you. This is a two-part question about ratio and also 6 feet apart, children remaining 6 feet apart while playing. Do you think the number should be lower in the classroom setting regarding ratio instead of 6 to 1 down to 3 to 1 in one room?
I need more context with the 3 to 1 and 6 to 1.
Yeah, so this sounds like an infant. We're talking about infants and toddlers here. And then the second part of that question is, or in a pre-K room, how many children should be allowed in one classroom? What are your thoughts about that?
So our cohorting size requirement is the same across the board, which would be less than 25. So if there is a school that does 6 to 1, it fits within our request. So I believe that is fine the way it is. And the second part of the question was?
The second part of the question is around the playing 6 feet apart. How will the children play 6 feet apart when it is not appropriate behavior for this group?
Right, so we would request outside as much as usual, and face masks should still be adhered to. Cohorting should be maintained. If possible, cleaning of the commonly used high-touch play equipment outside as well. And additionally, children under the age of 2 and under are not required to wear masks. So I would assume some of that question would be related to those that age group as well. And in the response to that, like I said, we ask for layers of protection. So since those children are not using masks and it's a little difficult to keep them the 6 feet apart, we would ask you to beef up the other things. So making sure their hands are clean, encouraging them to keep their hands away from their face and mouth, and continue with the other efforts with the low cohorting, I can't get the word out, keeping them within the same cohort while they're in the school.
Great.
I wonder if this might also be a good place for Damaris to talk about in her classrooms, what she's doing with the infants and toddlers, since they can't wear masks. How are they keeping socially distanced?
Sure. So in our infant toddler classrooms, our ratios are low, not to the Octal ratios. It's usually 1 to 4 in our infant classrooms through the HS guidelines, and we have it at 1 to 3. So our infant toddler classrooms are actually already low. So our teachers beef up, right? Those extra precautions. So that's why they are mandated to wear the additional face mask, the face shield, in addition to the face mask, and lots and tons of hand washing procedures as well. As far as going outdoors and play in the playtimes, our students actually have to wear their masks, and they give mask breaks. And when those mask breaks take place, there's nobody around them. So our teachers are very intentional about that. And they do, sanitize and disinfect right behind the children, walk around with hand sanitizers right behind the children as well. So I hope I answered that.
Thank you, Damaris. And can you just stay on for a second, because this second part is also for you. Do you have any recommendations for how to help children keep their masks on?
When we first started with the mask wearing and the age groups, of course, I was like everyone else, because I'm a parent as well, and said, how are children 2 years old going to wear masks all day? And those kids really surprised us. They really surprised us, because it became a norm to them, and they just were. And we just was very consistent about repetitive about, redirecting kids, hey, friendly reminders, to make sure that we were impunitive as well, right? So just reminding them and helping them, wear their face masks and making them understand, reading tons of books. And there's a lot of YouTube videos out there for making children understand. And as the kids started seeing that it became part of the routine, it just became part of the routine. I have seen children at 2 years old actually walk to the doorstep, and if they're wearing their face mask down, they'll put it up on their own. They sit down for the procedure, they put their foreheads forward, for the temperature checks. Like, they are pros now. They go straight into the hand washing. So I think that we underestimate children.
Yep, thank you.
You're welcome.
Next question. Is there a lack of in-school spread because schools have been shut down? And when the schools reopen, will that change? What are your thoughts about that?
No, that is not the case. The Archdiocesan schools began school on September 4th, and the child care centers have never been closed. And what we have seen out of the roughly 1,650 school child care centers that were open, as well as the 125 or so archdiocesan and charter schools that began in-person classes in September. Out of all of those schools, we have only had 9 schools that had confirmed outbreaks. So if you do the math, that's a very, very low percentage. So I do not believe it will be much of a change. If we do have more than 9, you would have to kind of consider the denominator of the schools. That would go up to probably about 250 schools within Philadelphia, as well as the inclusiveness of the 1,650 or so childcare centers. So I hope that answered your question.
Thank you. If schools have 0 ventilation on reports, is it safe for children to attend school?
0 ventilation on reports. Does that mean that there is a report that's sent to parents and that it's not mentioned?
That the ventilation, what I'm guessing is, and I'll ask Ms. Boyce to explain a little bit what she's talking about there, but I'm guessing that she saw a ventilation report and it said, and it had 0. The ventilation quality is 0. Does that mean that it's safe? But we'll get some clarification and come back. Next question.
Yeah, I'll have to come back to that.
Do we know if we can spread COVID after we are vaccinated?
I will throw that over to Nicole Spector or Dr. Burns.
I can take that one. We do not know yet. We are still learning about the vaccine, but we do know that getting the vaccine prevents people from getting very ill from COVID. There are very strong data that's showing that there is a very low or to none rate of hospitalization or severe illness after getting the vaccine after about a month. So while we don't know if there is still asymptomatic spread, we know that getting the vaccine is very important for reducing the disease burden in our community and preventing people from being very sick in our healthcare system.
Thank you. And you may want to stay on, Nicole, for this next one. What effect do these vaccines have on people with pre-existing conditions?
So there has been some research on this. The CDC says that the vaccine is safe for people with pre-existing conditions, except if you have an allergy to any of the components of the vaccine. The chance of a severe allergic reaction to either of these vaccines is very low. I can give you the exact numbers. Give me one moment. For the Pfizer vaccine, the chance of anaphylaxis or a very severe allergic reaction was 11.1 cases per million. And then for Moderna, it was 2.5 cases per million. So it was a very low chance of a severe allergic reaction. The only populations, and Julianne or Dr. Burns, you can correct me if I'm wrong on this or anyone else, but from what I have seen in the data, people who are immunocompromised, so people living with HIV or another serious immune disorder, they have not been able to do as many studies with people with these illnesses, so they're not entirely sure. But for all other people who have pre-existing conditions, it is safe and important for people to get the vaccine.
Thank you. When do we expect that childcare staff will be able to access COVID-19 vaccines?
I can take this one. This is Dr. Burns. So the week of February 22nd is when we expect school and childcare student-facing staff to be able to start accessing vaccine. These providers at the schools will receive notifications and instructions soon from the health department and the Children's Hospital Philadelphia, if that's a place that they can be vaccinated, about these opportunities. At first, everyone will not be able to get the vaccine in the same week. So this will be, this vaccination will occur for those who do want to get the vaccine over a few weeks. But within those few weeks, we hope that everyone who wants it and qualifies will be able to get that first dose of the vaccine. And then that will be followed up 3 to 4 weeks later with a second dose of vaccine.
Thank you. And just to follow up with that, will the city be able to prioritize those childcare providers who are already servicing children before those who are not servicing children at this time, but are doing so virtually?
Yes, that is an excellent question. So as we determine which staff are going to receive these first notices for eligibility to sign up for appointments, it will be tiered, and we will ensure that the first opportunities go to child-facing staff. So these will be, and I know in early childhood education centers, these are essentially most of the staff. So these staff will receive opportunities first, followed by those who will soon return to the classroom. And then really we're not focused on it at this phase, but in this much lower bracket in terms of priority are people like administrators who might not have any interactions with students at all and just be working from home. So they are not in that priority list. So these are anyone with this priority group. First is interaction, anyone who is child facing, has interactions or soon to have potential interactions with students. This also includes staff who interact at the daycare or school, including janitors, food service workers, other ancillary staff who are important to making these schools and daycare centers run.
Thank you. Thank you. Next question. Is the vaccine a one-time vaccine, or is it going to be ongoing like the flu shot?
Sure, I can try to answer that question. The answer is we don't know yet at this time. We hope to have more information as we continue to study this vaccine, and we continue to study the immune response of people who have gotten the vaccine. So we'll see. We hope that this vaccine provides protection that will last many months, a year. We hopefully maybe even more than that. But as time goes on, we'll learn more and more and determine if this is a shot that you just need one time. Of course, the first time is the 2 doses. Those 2 doses are very important to get, and to really make sure that you get that second dose for a longer lasting protection. But once you get those 2 doses, we'll have to see if you need any sort of booster shots, in some amount of time. So we'll hopefully learn more information as time goes by.
Okay, great. Thank you. Next question. If someone in a child care center has COVID, does the entire center shut down?
Thank you for that question. And the answer to that on its surface is no. What we would like to see is that if there is a child in a cohort or a teacher in a cohort, remember that little bubble meme that we put up. So the entire cohort would then be asked to quarantine for a period of 7 to 10 days following the CDC guidance. However, there would be a recommendation for the school or the child care center to pause in-person learning for that cohort for 14 days. So let me break it down, that there will be 3 things that occur. The individual that is sick with COVID will be asked to isolate for 10 days. Their close contacts, which would be everyone in the cohort, would be asked to quarantine for a period of at least 10 days. But we understand if 7 would fit your vernacular a little bit better than 7 to 10 days following the guidance. Then once you complete your quarantine period, you would not be able to return to the school until the end of the 14-day pause. You can, however, return to your other activities, walking a dog, going to a park, attending church, ensuring that you're following the city's current restriction guidance, as well as wearing the mask, socially distancing with other things, and hand washing.
Thank you. question about ventilation. Are there better solutions for ventilation than using window fans? What can you do in situations where there are no windows in the classroom?
So this is where we go back to that layered approach, right? The foundation being the mask use, hand washing, social distancing, in opening a door. Opening a door is also ventilation. If there is a classroom that is tight, we have also given instructions to the schools and childcare centers to try and utilize a bigger space. So if there's a cafeteria, we would recommend a larger space as well. If you remember what Dr. Kaufman was saying, if you take a drop of food coloring and put it into a gallon of milk, it's highly unlikely that that homogenized milk would take on the color of that darkest hue that's in the bottle of the food coloring. So ventilation could simply be being in a larger space. When that is not possible, you beef up the other options that you have available to you, or simply open a door.
Thank you. Next question. Are you seeing more child-to-child transmission in infants compared to other groups of children in childcare centers since they cannot wear masks?
I will answer the first part, then I'll throw that over to Dr. Kaufman. And in the school setting, it's a profound no. So I will send it over to Dr. Kaufman.
Thanks, Gail. So it's really interesting. There have been a lot of recent publications specifically focusing in on young children and infants in early childhood education. And when good epidemiologic studies are done, and there's been careful sequencing of a virus to really understand, are they related to each other? What's found typically is that the infant has either gotten it or is giving it to their members of their family, or if their family has had a social gathering, particularly one where the pass the infant game is played, that is where their transmission. I know of one report in which there is 1 or 2 infant to infant transmissions that occurred in a classroom, and that was from Utah. And this is with tens, if not 20 of thousands of cases, observations of children, young children in early childhood education. So I think it's really quite notable that infants do not seem to pass it to each other. And just as a epidemiologist, I'm really interested to think and study that more, because there's something there that seems to be unusual.
Thank you. You may want to stay on for this next one, Dr. Kaufman. Are children more susceptible to the new variants?
There's no data that I know of that shows that children are more susceptible to the new variants. I think the idea there is that everyone may be a little more susceptible, but that it's not an age-related difference in susceptibility.
Gotcha. Thank you. Thank you. Another question about fans. I'm not sure if you've answered this already, Gail, but could you clarify the use of fans in an indoor space? Specifically, are fans good?
Like I said before, fans are an additional layer of protection that can be utilized. And if you are using a fan, it should be in a window, and should be exhausting out. So pulling the air from the room and pulling it out, as opposed to pulling the air from the outside and pushing in.
Thank you. Next question. What if a family child care home have a case where a child has COVID-19? How long should they stay closed?
So the recommendation is that if it's a family child care center, in my experience in this position, those are fairly small cases where it's less than 10 people in that cohort, and it's generally just one cohort. And the recommendation would be that that child care center, that small home-based child care center, should pause for 14 days. And the individuals should quarantine for a period of 7 to 10 days, preferably 10 days.
Thank you. How many contact tracers have been hired since March?
Thank you for your question yet again. So within our department, there are about 200 contact tracers and contact investigators that the demographics spread the span.
Thank you. Most of the studies, and I was informed, so this is one of the questions. I was informed that most of the studies looking at child-to-child transmission were in rural areas. One, is that true? And then two, have there also been studies done in urban areas, specifically in Philadelphia? Dr. Kaufman, I guess that would be for you.
I guess so. We have, in Philadelphia, as you know, had very little opportunity to study large groups of children in school because our public schools haven't been open since March. The best data that I know about comes from Rhode Island, where they do have quite a few pretty big cities and cities with really wide sweeps of diversity, racially and economically. And they have been able to have very, very low rates of transmission in their childhood, in daycare, as well as in K through 12 schools. The New York Times just published an article within the past 2 or 3 days on the Rhode Island data. And so that is an example that feels a little closer to home when people say Wisconsin doesn't count. Mississippi, I think, actually does count when you look at some of the places that were studied in the Mississippi study. But I really do think that there's a lot we can learn from the Rhode Island data.
And this one, next one is for you as well. Are there any differences in risks to children who contract COVID-19 for infants and toddlers versus 3 to 5 year olds in terms of poor outcomes for those who are sick?
I think overall what we see is that the even in childhood, the older you are, the more likely you are to have a more symptomatic illness. And we don't know exactly why that is, but you're less like, as you get older, you're less likely to have an asymptomatic infection. You're a bit more likely to require hospitalization. And the kids that do require hospitalization tend to be the very, very young babies because they have unexplained fevers, but not because they're really sick from respiratory illness, as well as oftentimes school-aged and teenagers, school-aged kids and teenagers, typically those who have underlying health conditions that are not well controlled.
Thank you. Thank you. All right. Next question. What will
Michelle, if I may, sorry about that. If I may add to the transmission question real quick.
Yes.
Just something to go, I think Gail already mentioned this, and we also kind of depicted some on our epi data from our surveillance, ongoing surveillance from the cases in the city. Most of the transmission that we have seen, and unrelated to even school transmission, a lot of the transmission has been mixed. That being, social transmission from extracurricular activities, from the home. And rarely have we seen a case that is just in school transmission. And so that is something to be wary of. And I think it pretty much is reiterating and reinforcing everything that you may have heard today. But I think that mixed approach in a cohort is something also why the 14-day would make sense, because that transmission, when it is mixed in that way, is very hard to track. And so that's just my little bit that I wanted to add from what we have seen from surveilling the cases since, I want to say, we started doing that in October.
Absolutely. Thank you. Thank you, Tanya. Next question. What will change for teachers following completion of COVID-19 vaccine protocols? Gail, you spoke to masks still being required after that, but what about the quarantine following exposures?
So CDC did release some new guidance yesterday. We are in the midst of updating that guidance, and when it is updated, I will send that out to Sean and to Diane so that we can get that out to you in a very pointed way so that it makes more sense. The CDC guidance is pages long, but what they're initially saying is, do people who have the vaccine, will they still have to quarantine and isolate? At this time today at 6:16 p.m. with the PDPH, the answer is yes. We will, in the midst of updating our guidance, and when that happens, we will get that information out to you en masse.
and mask wearing will still be required.
Correct.
Great, thank you. How is social distance practiced in a group home daycare?
I don't know that I could answer that outside of what we offer to them is to do the best they can. I don't know if there's anyone on the call that could answer that.
I can try to answer that question because we did do a small research study in New York City of home-based providers and the practices that they put in place shortly after the pandemic started. And a lot of the practices they put into place had a lot to do with the activities that they normally would partake in. So for meal times, instead of eating meals family style, they had the kids kind of sat individually and had partitions around them. So some of the practices aren't really that different from a small childcare center, even though, you know, space-wise it's different. And we do have to keep in mind that the ratios have also gone down for not just for childcare centers, but for family group daycare centers as well.
Great, thank you. Thank you for jumping in on that one. Next question, as for the classrooms, will each student have protective barriers around them? And will teachers be wearing masks with face shields? So this could be childcare and school-based at the same time.
I will turn that over to maybe Damaris if she could answer, or if there's anyone else that could answer logistics for schools.
I mean, I can answer for us as far as face shields. We do require all of our teachers and all of our staff wear face masks. They are required to wear face shields in addition to the face mask if they have a child that cannot pull or take apart, take off the face mask or put on a face mask. Typically with our special needs children that they need the extra support. So those teachers have to wear a face shield, an additional layer to protecting them. As far as barriers are concerned, our school-aged classrooms have barriers. So I purchased additional tables so that way we can promote when the kids have their face masks off and they're eating meals, we can sit them separately, still with each other, but safely apart where they can eat meals without their face masks, if that makes sense.
Thank you, Damaris. I just wanted to point out how Damaris really illustrated very well how she took measures to add layers on top of the guidance that we've already provided. So the face shields, as well as the face masks for individuals who can work with children who may not be able to wear face masks or are too young to wear them, gives them an extra layer. So we want to just point that out, that a layered approach is always going to be the one that's the best.
Thank you. Will staff living outside of Philadelphia County be able to receive the vaccine?
I can answer that question. This is Dr. Burns again. So the Philadelphia Department of Public Health is committed to vaccinating all school and childcare staff within Philadelphia. So you will not be excluded if you live outside of Philadelphia. If you do have the opportunity to get the vaccine outside of Philadelphia, if you live outside of Philadelphia, please take that opportunity if you have the chance to get it sooner. But residency will not be a requirement for the next phase of vaccination.
Great, thank you. Next question. What are the protocols, and I'm paraphrasing this one, this is a long one. What are the protocols if someone has side effects after the second vaccine, that side effects that look like COVID? Do we have to test for COVID before returning? What are the protocols? So someone receives a second shot, shows symptoms of COVID. What are the protocols?
So the vaccine does not cause COVID. I think the doctor and Nicole did mention that. When there are more than one symptom available for this individual, and it should last past, I say, a few hours after the dose has been given, the recommendations that the clinicians on the COVID containment division have been giving is to go ahead and seek the testing because a person could have been positive for days before and just not symptomatic until after. So we do see people with symptoms after the second dose, but for that extra layer of protection, testing would be recommended. And what we would ask this individual to do is to wait for the results for the test to be before they return to their normal activities. So before returning to work, church, or other activities that they should do in the community.
Great, thank you, thank you. What do you suggest for individuals with autoimmune diseases working in high-risk situations?
Is this a vaccine question?
Nope, this is just about COVID-19 specifically.
So there are high-risk illnesses that we look for to identify those individuals as higher risk, and they can work alongside with their doctor to determine if they're one of those high-risk categories, to determine if it would be unsafe for them to work in public-facing positions such as essential workers, hospital work, etc. And if there are additional questions related to their specific illness, they can call the 215-685-5488 phone number to speak to one of our guidelines clinicians so that we can give a better answer as well, based specifically on their illness. I don't know if Dr. Kaufman would like to add anything to that.
Not really. That's spot on. I think this is really a decision that's best made by the individual with the condition and their physician, because only they know just how significant and threatening an infection might be for them.
Great, thank you. Are child care centers mandated to report COVID cases? How many child care closures have happened in Philadelphia since the beginning of this crisis?
Yes, they are mandated to not only report to us, but to their credentialing agencies as well. COVID-19 is what we call a reportable illness. So all COVID-19 cases must be reported, whether it's through the school, through the healthcare provider, or for themselves if they know prior to their healthcare provider. That notification would go through one of two ways. The lab who is actually resulting the actual COVID test would result that to the state, and the state in turn notifies us. Or if it's a rapid antigen test, at times the individual will call that 685 number, or the school will notify us as well via the 685 number or through our COVID hotline email. And as for the number of closures, that is a figure that I don't have currently, but if you're interested, I can get that back to the leadership that's on this call.
Thank you. Specifically, how many cases do we have this information? How many cases, how many cases of COVID in children in Philadelphia?
I do not have that record. That would be a stratification that would be something that would take quite some time for us to collect. I could bring it up to our epidemiologist, but I do not have that answer currently.
Thank you. Hold on. My screen is jumping here. Damaris, thank you for your expertise. Has your center experienced any COVID cases in the past year?
Yes, we have. We have experienced a few, actually.
Thank you. Can you address the conditions? Excuse me, hold on. I skipped a question. What if your center is in Montgomery County? Will we still be messaged to get the vaccine?
I can try to answer that question. To my knowledge now, we are just focusing on the centers and schools inside Philadelphia. As you know, each county has their own vaccine distribution and receives their own vaccine. So Philadelphia is separate than the state. And so if you're in Montgomery County, they will receive vaccines from the state. So they should have opportunities for vaccination soon within your county that the staff from that center can take advantage of. If there's specific questions about a school or center, I can always follow up by email, or you can contact us about that specific center, and I can get back to you in terms of more information.
Great. And this looks like this may be next to the last question. If a child is obese and has asthma, would you recommend they go back to school?
I'm going to ask Dr. Kaufman to weigh in on that one.
Sure, I'd be happy to. I think it is important to recognize that we do have a lot of kids and adults in our community who do have risk factors, and asthma and obesity are two of the most common risk factors. All of the safety really depends on how well controlled the conditions are. If somebody has diabetes and obesity and asthma, and either the diabetes or the asthma is not really well controlled, that's a good time to have a conversation with your doctor where you talk seriously about weighing the benefits of in-person education versus the risks of in-person education.
Thank you. Thank you. There is a question about, it's a long question, coordination between when educators will be receiving vaccination and also when teachers or when schools are scheduled to reopen on the same day. So there's a question about, has there been any thoughts given to that timeline?
Can you repeat the question, please?
I was trying to be nice about the question. Why would schools reopen for children on the same date that vaccination clinics start for teachers?
So I'm going to go right back to the layering aspect of COVID-19. We now have vaccines. This is an additional layer of protection to mitigate the spread of COVID. Unfortunately, the vaccine will not prevent COVID from spreading if people are not using the other strategies as well. So as for the school district opening up on the same day that we start, I cannot answer for that. That is a question for Dr. Haidt.
Yes, yes. As probably is this final question about fans blowing and asbestos and mold particles blowing around in the air. So with that, that concludes all of the questions that we have related to child care centers. And if there are any other questions, you have probably about a minute or so to get it typed in the question and answer section before we close this out. But thank you, and I'll be turning this back over to you, Gail.
So I'm not going to give a long spiel, but what I want to make sure that the message that we have given to all of the people who are on this call this evening is that there is evidence to show us that the foundations of the 3 W's that we preach for the last year works. COVID is not mysterious in the way that other people would think. It's pretty easy to kill it with hand washing and using 60% alcohol hand sanitizer. It's also fairly responsive to wearing a mask and social distancing. So you will continue to hear that over and over and over again. As for the vaccine, now that we have it available here in Philadelphia, my colleagues and I are working fervently to make sure that we can bring this out to the masses in a way that is equitable as well as fair for everyone that is here. And we wanted to make sure that we keep the early childhood education sector first and foremost. You guys have been open since the beginning. There was never a closure related to the fact that, hey, we closed the schools, now we would like the early childhood centers closed. We've recognized your work. We recognize the parents are in need of keeping this sector open. And together, I think we can do a great job in making sure that this remains safe. With that, I'd like to see if my colleagues from PDPH or Dr. Kaufman have any parting words.
I'd just like to echo what Gail closed with. I know that I and so many of my colleagues and so many of the people I encounter every day are incredibly grateful for the work that our teachers in early childhood education are doing, and recognize that oftentimes you're not always called out and included as broadly when there are other discussions of the challenges of education in the time of COVID. But I do know that your work is valued, and you've obviously been doing a great job because you've been able to keep daycare settings safe.
With that, I think we'll close. Again, thank you everybody for joining us today. I think that we've presented a lot of information, asked and answered a lot of questions. I'm sure that we weren't able to cover everything that people wanted us to talk about today, but I hope that it's a good start. I will give one last plug for PCCY. We are putting together a group of parent advocates who are passionate about early childhood education, who want to work with us to advocate with lawmakers for more funding and more support for early childhood, specifically childcare centers, pre-K and Head Start. So I'm going to drop a link in the chat. If you're interested in meeting with PCCY and becoming a parent advocate, if you're interested in meeting with your lawmakers and talking to them about how important early childhood, high quality early childhood is, please fill out the form and we will get in touch with you. We're hoping to do a training in mid-March for parent advocates so that we can work hand in hand to improve quality in early childhood and also get more funding for it. Thank you everybody for joining us. We hope you have a good evening.